Dr. SOMASHEILA Murthy from LVPI Hyderabad, who would be talking on HLA-B27 associated uveitis and role of microbiome. I wanted to have actually the immune-mediated uveitis, the basic understanding to improve, and microbiome, proteomics, and immunomodulators has helped us to understand the disease much more.
Very good afternoon, everybody. I apologize for my being late to reach this session, and I'm sure you must have had a very interesting session so far. I'll wrap it up with an oft-repeated topic, so I thought I'll cover a few different aspects in HLA-B27 acute anti-uveitis, and then move on to ocular microbiome. So the two a little bit unrelated in certain ways kind of topic. So we all know that it's non-granulomatous inflammation, and it's an alternating uveitis in either eye. Very rare that I know, I'm not even sure if you have a patient presenting saying that exactly on the same day they had the disease in both eyes. It's usually sequential, very rarely simultaneous in that way. So the prevalence of HLA-B27 in patients, depending on which study you look at, varies from 50 to 75%. And at least in my clinic, because I'm more of an anterior segment specialist, and I look at a lot of anterior uveitis, most of the patients that I see with this entity, and for me, age is not really a criteria. I've seen many older patients also present for the first time to us, but then they turn out to be HLA-B27 positive. So this is my initial test. I put their money on this test for patients with non-granulomatous anterior uveitis, even if they can have severe presentations, such as when they walk in with a very bad-looking hypopyon kind of a uveitis, or they have a very low-grade inflammation. So either of the two. So we all know that it's a male preponderance. We know that there are always recurrences, maybe one episode a year, maybe one episode in 5 years, maybe multiple episodes in the year. So the hallmark would be that every time the episode comes in, if you identify and treat it adequately, so the mean duration of resolution would be about 4 to 6 weeks per episode, and it improves very well with topical medication, we all know that. But in patients with multi-recurrent disease, and if you're not aggressive enough when they come to us, or we don't use treatment adequately, then they do end up with problems such as cataract most of the time, or cystoid macular edema. And especially some of our patients land up, and it's probably more in the Indian subcontinent or in our context, they come to us with undetected HLA-B27 systemic manifestations, that they've had the ocular disease for years. So they land up with the cataract, and then you have a patient in front of you with active inflammation, and you have to operate on these patients. So this is some of the patients who show up over the age of 50 or even 60, and literally you're the first person to diagnose that the patient has ankylosing spondylitis or some of the other associated diseases where you have an HLA-B27 spectrum in all of these 4 that I've listed. And this is one of my patients who presented to me almost when he was 59 years of age, and presented all his life he had bilateral sequential recurrent anterior segment inflammation, always used some medication prescribed to him, and then he would get better. And then when he came to me, he had very advanced ankylosing spondylitis, as well as bilateral cataracts and active inflammation. So we had to control everything and then go ahead and do surgery for him. So the less known aspects is what I thought I would just quickly roll in, is the posterior segment complications. And based on the literature that I searched, it can vary as it's usually not expected to be very frequent. Perhaps we would average it out and say less than 25% patients would have posterior segment involvement or complications or posterior segment inflammation. And this you can see as vitritis. Very often it's a spillover vitritis when you have a very dense anterior part of the inflammation. Pars plana exudates are very rare but have been described. You can have papillitis, which is just another sort of a sign that you have in quite severe inflammation, and very rarely retinal vasculitis as well. Cystoid macular edema is more related to the chronicity of the disease, the multiple episodes, and perhaps maybe not adequate or less aggressive treatment. And chororetinitis and vitreous hemorrhage are extremely rare. So intensive topical steroids is the need. And of course with mydriatic cycloplegic agents for these patients. And this is one of the entity where if the patient comes to you, literally you're like a magician for the patient, because in a few days the patient gets intense relief from a very severe symptomatic disease. And even if there's a coagulum, the patient sometimes presents to us with hand motions or a counting figure vision because of the coagulum covering the pupillary area. So the coagulum just shrinks over 2, 3, or 4 days, and the patient starts reading on the chart and feels like you're some sort of magician. You're not. It's just how the disease responds very well to topical steroids. So what about the other agents? As Dr. JB mentioned, that we really try to move away from systemic steroids, as Dr. Vishali Gupta presented to us so eloquently, that systemic steroids cause so many side effects. So we often see that many ophthalmologists tend to start oral steroids for these patients because the disease looks very intense and very scary and severe. You don't need to. Or if at all you really must, for the patient to rapidly get better, I think a week is adequate, and after that topical steroids do take over. So systemic steroids are very less frequently required, and in most of the studies that less than 5% patients or a very small concentration of patients would need systemic steroids for long term. Instead, if the patient has multiple recurrences and needs long-term therapy, it has to be immunomodulators. This can be either in association with the treating physician, the rheumatologist, or if it's only ocular, then if you're comfortable, you can undertake immunomodulator therapy for these patients. Some of us, we do use systemic NSAIDs. They have not a very intense role in the management, and of course, periocular steroids for those patients with cystoid macular edema. So the prognosis, according to me, is extremely good if treated well. The common complications, you can have cataract, which is most frequent. Secondary glaucoma would be either if the patient is a steroid responder, which can happen, or if it's missed and the patient develops sort of a pupillary block. So these are the two causes of secondary glaucoma. And it's really a poorly treated disease that causes this secondary glaucoma complication. And some patients very rarely can have chronic anterior uveitis, and those patients I would put them on immunomodulators right away. So that was just in a nutshell about HLA-B27 disease. I'm moving on to the role of the ocular gut microbiome in uveitis in general, and almost similar results that we have seen in some of our patients with HLA-B27. So of course here the entire work is credited to Professor Shivaji, who was our director of research, and it's his project that he has extensive experience in studying the gut microbiome in various diseases, and his entire team, of which we were part of. So the microbiome, because it may be new for some of you here, it's the community of microorganisms all put together, which are termed the microbiome. And the gut at birth is sterile, but then very soon it gets populated by the normal, what you call commensals of the gut, and this is what keeps us going, in the sense that it varies with age, ethnicity, diet, there's genetic variation, and then there's pathological conditions based on so in young people we see something called more of actinobacteria, and then in elderly individuals the more of proteobacteria. So this reflects upon, as we grow older, the disease associated pathogens increase. So is it important? Yes, it is, because it carefully balances what is good for us and what is bad in terms of the opportunistic organisms. And all of our diet and everything of late has been attributed to an imbalance in the gut microbiome, leading to manifestations in various diseases. So it's this gut microbiome displacement, or a bad microbiome, is called dysbiosis, which is implicated in several of these autoimmune diseases, and of course uveitis is one of them. So it can be associated with uveitis as well. So taking that as a hypothesis, what we did was to look at the gut microbiome in patients with uveitis. And it was a very systematic kind of work that was undertaken by the team, which I will not go into, and just sharing some of the clinical data in which we had patients, we had a wide group of population because of the nature of the work involved. We had to take with patients from different diseases, not just HLB27, that was a subgroup of this. And the contraindications, we had to be very certain that we're not looking at patients with other disease, so we had to make sure that we didn't have those in them. So this is going to be a confusing slide, but in a nutshell, what we saw, and I'm just putting it very simplistically without taking up too much time, is that in our healthy controls, which we obviously needed healthy controls, we saw that the beneficial or the anti-inflammatory or the probiotic antimicrobe agents, the anti-inflammatory gut flora, their population, which I've put in blue, was much higher. Whereas in the patients with uveitis, and we could show it was very significant that the pro-inflammatory pathogens, their population was much higher, what is listed down there in the white box. So in other words, what it does mean is that it's not just various other diseases such as I mentioned earlier, for example, even cancer and so on, but it's also in the ocular diseases, uveitis and in Behçet's disease, specifically in anti-uveitis. So this has been shown either in the murine model or even in patients, as well as age-related macular degeneration and dry eye and so on. So bacterial and fungal keratitis was published by our same group. So it has been shown that there's change in the gut microbiome due to dysbiosis in various ocular diseases. So what we concluded in our paper was that the uveitis patients, they had an altered gut microbiome, and they were the anti-inflammatory gut microbiome were less, whereas the pro-inflammatory and pathogenic kind of a gut microbiome was much higher in patients with uveitis. So where does that lead us? Perhaps obviously in towards our therapy, and to get rid of, it's very simplistic to say that to make the patient better, we can just alter the gut microbiome and improve it. But perhaps it's a huge interrelated cycle. That's just one of the factors. Perhaps that's an easier thing to improve. So perhaps we can improve that as well. So thank you once again for accommodating me, Dr. JB, and thank you everyone for listening.